So you have to make sure that is for the first person.
Okay, and that's
Where
for the
is that?
second one.
Mariana.
Yes, it
You
is.
have Mariana? Okay.
Okay, welcome to the second session of this conference on data quality. My co-chair is Anne Corrier from Kenya, and I'm Anna Gavin from the Northern Ireland Cancer Registry. Our first speaker is Mariano de Camargo de Cancela, who did her doctorate in dental surgery in Brazil, and she then did specialised studies on community health in France, where she did her master's degree at Lyon, and followed by research at IARC within the screening group. She stayed in IARC for her PhD, and since March 2011, she holds an epidemiologist position at the National Cancer Registry of Ireland and is currently involved in prostate cancer and breast cancer research. Mariana is going to talk about biomarkers and their implementation in cancer registration, the example of the HER2 testing in Ireland. You're very welcome, Mariana.
So I'll start by making a brief introduction. I think it should be fine now. Okay. Well, good morning. So I start making a brief introduction to show you the context of this study. So breast cancer is not considered a unique disease anymore. So there are 4 main breast cancer subtypes, and they are classified according to the receptor status: estrogen, progesterone, and HER2. And so there are 4 main subtypes. I'm going to talk specifically about HER2, that's the human epidermal growth factor receptor 2. It's amplified in approximately 20% of breast cancers, and it's important to have this test because the cancers that are positive for HER2, they have a worse prognosis, but they are eligible to have adjuvant therapy with trastuzumab. But this is not without consequence because trastuzumab is cardiotoxic and has a very high cost per year. Now I'm just going to quickly talk about the main tests for HER2. So there are 2 main tests: immunohistochemistry, which is measured by membrane stain using the ORED score, and fluorescent in situ hybridization, the FISH test. So the breast cancer specimen is sent to the laboratory, then it's tested by IHC. The result can be negative, positive, and for a small subset of tumors, the results will be equivocal, or they are inconclusive. You cannot affirm that they are negative or positive. So this subset is advised to be retested using a FISH test, which is more accurate, and then again can be negative, positive, and a very, very small subset can be equivocal again, then it's advised to be retested using FISH. So I'll talk about the method. So this study has 3 parts. Well, the first part, we evaluated the time trends of HER2 test results that were originally recorded in the registry for the period 2002-2008. The second part was the data re-abstraction of the subset having equivocal results. And so the tumor registers officers, they went back to the medical records to re-abstract information to verify first whether the equivocal case had a second FISH test, and if had, which were the results and which was the second test employed. And this also for the case 2002-2008. And finally, the analysis of the predictors of HER2 testing in Ireland, this with 7,619 cases, for the period 2006-2008. We chose this period because of the completeness of the registration, that we had information for almost all the cases, and the registration became stable. For this, we used a logistic regression, where the outcome was not having a HER2 test recorded. And it was adjusted for clinical and sociodemographic variables. So now I'm going to show the first results, the HER2 recording over time. So here in the bars we have the number of cases, and the line is the percentage of recording. So you can see in 2002, it started with 42% of cases having a test recorded, and then it increased by 2006. The trend was flattened and reaching 87% of tests recorded. The main reasons for this is implementation and using routine clinical practice of these tests and the availability of the testing in Ireland. In the early years, many cases, they were sent to other countries to be tested. Well, not the case, but the specimens. And so that's why for the third part, we chose this period also. Now I'm going to talk about the re-abstraction of the data for women with equivocal results. So here are the cases that we had information on HER2, the 87% of our cases. 87%, no, it's around 70% for the 2002-2008. And so 7% of cases had unequivocal results. So this corresponds to the 870 cases that, so the TROs went back to the medical records, and they found 410 cases that were retested. So 325 were retested using FISH, as advised by the guidelines, and 85 were retested using IHC, which is not recommended. So the rate of equivocal cases using FISH was 2%, and using IHC, it was 24%. And 460 patients had no evidence of retest. Well, now, so the new values of the retest were incorporated to the data set, and then we used to define the cases as positive or negative. But for the 460 cases, we could not assign a definitive value. So the factors affecting test receipt. So for this, I used the subset 2006-2008. Here, I'm just showing some geographical variation. So it ranges from around 7% to more than 30%, the rates of non-testing. And overall, it was around 15% of cases that had no test results in the data set. Now I'm just going to show the distribution by the clinical characteristics. So stage, as expected, most of the cases without a stage attributed, they didn't have a test result. Surgery received the same. Cases having no surgery were less tested. Type of hospital, cases passing only treated in public hospital, they were less tested than cases going to private hospital in any moment of the treatment. And screening, non-screen detecting were less tested, slightly less tested than screen detected. And now I'm going to show the distribution by the social demographic characteristics. So by age, while patients older than 70 were less tested. By the deprivation index of area of residence, the deprivation level of area of residence, there was not a big difference. And by marital status, non-married women were less tested than married women. Well, all these variables were included on a logistic regression model. And now I'm going to show the results. So the age and deprivation level were not significant in this model. Non-married women, they were more likely to not be tested compared to married women, and the odds ratio was 1.3, and it was significant. Well, stage was significant, and the risk was increased for women who did not have surgery compared to women who had surgery. There was significant difference by area of residence. Well, it increased or decreased the risk according to the area. And in private hospitals, so they were less likely to not be tested among non-screen detected cancers. So just to summarize the results, the record of HER2 results increased over time. Well, after the additional collection of data for the equivocal results, we could not assign a definitive result to part of the cases. And marital status and area of residence predicted whether a woman was tested. Well, now I'm going to talk about the implication of biomarkers for cancer registration, because many questions and challenges arise when a biomarker is introduced in clinical practice. Well, the first question is this going to be routine? We never know if it's just being used temporarily or if some new biomarker will appear. And so this is the first question before including on a cancer registry data set. Then when to start to record, because also when the biomarker starts to be used, there's some inconsistency regarding test results and how to quantify and how to attribute positive or negative. And so are there different tests and how to record the test results. So the lessons from HER2, well, the first thing is that if possible, cancer registry should collect raw values of test results in order to be able to adapt to changing guidelines and cutoff values and to keep a record of the test used. Because some cases they can be positive and become negative or the opposite. Oops. But, well, are the pathology reports detailed enough? There are some things that doesn't depend only on the cancer registry. So for the future, well, now our data set, we have information in receptor status, it's stable, it's complete over time. But what's next? Now, maybe 10 new breast cancer subtypes, and the same questions and challenges will appear again. Well, thank you.
Thank you, Mariana. Thank you, Mariana. We have time for 2 questions. Yes, Sabine.
Deirdre Murray, National Cancer Control Programme. Thank you, Mariana. Very interesting for the cancer control perspective. I'm just wondering, did you have a look at 2002 and 2008 in terms of the differences between, let's say, equivocal results between those 2 cohorts at all, or did you look at it in total?
The equivocal results, actually, most of cases that were re-abstracted, they were on the most recent years. It was quite difficult to find a retest with FISH in the early years.
Hello.
Okay, Sabine.
Thank you for this very interesting talk. I have a question about, you stated in your abstract as well that socioeconomic status was influencing whether there was a test result or not. Did you have any information on the treatment as well? Because if there is a relationship between testing or not and the socioeconomic status, and that should be having a relationship with treatment as well.
Well, the information on treatment, so we had a surgery receipt, so whether women had or not, and this was significant. So women without surgery, they were less likely to be tested, but the deprivation status didn't affect when it was mostly geographical area of residence rather than...
But you did not have any information on the use of trastuzumab?
Sorry?
You did not have any information of the use of trastuzumab?
No. This was not possible to...
Okay, thank you very much, Mariana.
Okay, thank you.
Our next speaker... Our next speaker is Isabel Zugasta. who is the director of the Basque Cancer Registry in northern Spain since it was set up, and is one of the persons involved in the network of Latin America cancer registries, REDEPICAN. And Isabel is going to talk about REDEPICAN guidelines for external evaluation of population-based cancer registries. Thank you very much, Isabel.
Thank you. Good morning. Thank you very much for giving me the opportunity to present you the guidelines for external evaluation of population-based cancer registries created by the REDEPICAN network with my colleagues that you can see there, and I will be talking on behalf of all of them. These are the places where they are working, as you can see, in several countries, and those are the institutions which have supported this project along those years. The REDEPICAN is a red, Latin American red, with groups working on epidemiology and information, cancer information systems. It was launched in the year 2008 with 8 groups, and 2 years later, in 2010, 2 more groups were added, one from Spain, one from Ecuador. And one of the objectives of this network was to establish a procedure and a structured protocol to evaluate cancer registries from an external review teams. Well, maybe you can see here the countries which participate in this network. In America is Uruguay, Argentina, Ecuador, Cuba, El Salvador, Guatemala, Honduras, and in Spain there are 4 groups. So the objectives of the project I am going to present you were to elaborate REDEPICAN guidelines for external evaluation of cancer registries and to pilot these guidelines mainly in Latin American and Spanish countries. The method we follow was the first step to create a working group with experts on cancer registration and medical audit. We elaborate afterwards the evaluation guidelines with a protocol and a set of documents auxiliary for the guidelines. And we celebrate several consensus meetings in order to agree with the items we have already defined and also to give the points. Because we first defined what the criterion and standard was, and we defined the criterion as an aspect of the activity of the cancer registry with measurable characteristic and observable. And the standard was the reference point that we were going to give to each of the items we defined, attributing a quantified value. We have 2 essential references, among others. The first one were the standards of cancer on cancer registration given by the North American Association of Cancer Registries, and the criterion they were using and we were following in a way were the completeness, the duplicates, the percentage of DCOs, and all of this. And the other essential reference was the indicators that you already very well known in cancer incidence in 5 continents as the percentage of cases diagnosed with microscopic verification, the percentage of DCOs, and all of this. We define 7 sections, or 7 sections, and in each one of them, and these are the sections we define, and in each one of them, several criteria were included, and the main characteristics were that we consider the criteria essential and not essential, and we give them several points with the standards we were defined. The fieldwork includes training courses for reviewers, the evaluation of the documents we sent to the registries before the visit, and the pilot studies to evaluate the guidelines. The main activities during these years included those of what I said, and the pilot study with these cancer registries that you can see there, Murcia and Albacete in Spain, Uruguay, Córdoba, Panama, and Manabí in Ecuador. The evaluation guideline includes 68 criteria. Each one had 3 standards of levels of compliance, and the maximum score that a cancer registry can get is 350 points. And as I told you before, we consider 10 essential points. We give them 40 points. And according to the score, the registry could be qualified as fair, good, or excellent. This is an example of the sections and the criteria we were using. The first one in the section of registering practices, the criteria was related to the incidents and how is it. And because it was considered an essential item, we just give 5 points. I mean, there were no 3 levels. And in the second one is the dissemination of the results. And, as you can see, we assign different points if the dissemination of results was 4 years or more than the real time. We just give 1 point. If the results were disseminated between 2 or 4 years, we give 3 points. And if the results were just disseminated before 2 years, we assign 6 points. So we elaborate a series of documents, as the guidelines, of course, and we elaborate as well several documents to send to the cancer registry before the visit. We design as well questionnaires for in-person interviews to different, let's say, members of the advisory committee, the cancer registry director, registrars, and technicians. We elaborate as well the guidelines for reviewers, and finally, the evaluation form. The pilot study included these registries, 2 in Spain and the rest in Latin America. And the results, after the pilot study, was that one of the criteria we have already designed was deleted, that several criteria were a little more refined in the wording, and interviews with the administrators and data providers, it was useful, in our opinion, to expand the concept of quality in the cancer registry and to better incorporate the needs of the clients of the cancer registry. And in that way, the section of dissemination of results was given more weight than in score. This is the results before and after the pilot study, and as you can see, the registration practices were slightly modified, the completeness and validity a little bit more, and the dissemination was increased in the value of the weight. So in total, the structure is given 17% of the weight, to the procedures in the cancer registration 64%, and to the dissemination 19%. Now, in conclusion, a part of the final score of the cancer registry got, or how the criteria in the registry performs poorly, in our opinion, the guide should be taken as a guide to continuous improvement of the quality of the registry, more than a reason for discouragement. On the other hand, the documents and the self-evaluation of the cancer registry, in our opinion, they are important opportunities and tools to improve the relationship between cancer registries and their institutions. The guidelines we have already designed were feasible and easy to administer and very useful in the process of continuous improvement of the quality in the cancer registries, particularly in Latin America. In one of them, Panama, that it was already starting, we found that it was important in order to push, to continue with the registry. And, these guidelines are finalized and ready to use in some of the cancer registry and in other countries. Here I am going to show you very quickly which are the 10 essential criteria we have defined for the cancer registries in order to continue with the evaluation. As you can see, in some of them, we just give a measure of a percentage and include several very, very basic criteria and very basic activities. Thank you very much indeed. Muchas gracias.
Thank you very much. Thank you very much, and for keeping well to time. Questions? We have one over here.
It's over there.
René Otter from the Netherlands. I would like to ask you, have you seen, as in your conclusion you mention it, differences between what you find in Latin America and in the two registries of Spain, which exist for many years?
Well, one of them it was not for so many years. The difference mainly were related to the essential criteria and to some of the value. The value got by cancer registries in Latin America or in Spain. So let's say that in Spain, the score, it was better.
Was it better organized, or because you have three different parts where you wait on it, on the structure, on the procedures and dissemination?
Well, I mean, that is an abstract because it includes the 7 sections and the 7 sections, 68 criteria.
Yeah, but there was not one section or one part where you could find main differences?
Yeah. Well, I mean, in the performance, in the what is the common activities, not the structure, but in the common activities, where the weight given, it was 64%. It was the great differences. And one of the activities of the network, in fact, was to create a guideline for a manual, for a procedure manual, because it was something that we already see that in many, well, I mean, several of the cancer registries were not existing.
Okay, thank you.
So it was one thing that we also did within the WEN network.
Thank you.
Thank you. Any further questions? Could I ask what the registries themselves felt about it? How did the registries feel about the assessment tool, and how easy was it to use?
Yeah. Well, I mean, at first, they were a little bit aware of what's going on, but when they first received the first documents and they have to really analyze things, I mean, they already knew, how things were going to be. And after that, because we did as well interviews with some people of the the Cancer Registry Advisory Committee and so on, I mean, they saw that it was quite interesting because the rest of the people around and the people supporting the Cancer Registry, they knew more about what they were doing. Some of these holes or poorly criteria, they were much better understood by these the funding researchers, the funding people. And so I think in general, they feel quite glad about the review.
Okay. Thank you. Any further questions? Okay, I'll move over to my co-chair.
Thank you, Isabel, for that exciting presentation. Our next speaker is Dr. Rozier Ozdemir Sonker. She is an epidemiologist and a registrar at Izmir Cancer Registry. Dr. Rozier is also a midwife by profession and a teacher, and she has a public health degree, and her thesis, a doctoral thesis, was on quality of death registration. She works in the public sector and has also worked in Izmir Cancer Registry for about 4 years now. She's going to present on the evaluation of a new death registration system in Izmir Cancer Registry in Turkey. Welcome, Dr. Rozier.
Thank you very much. The name of our study is an evaluation of the new death registration system of Turkey in the case of Izmir province. The data on the cause of death are not available in more than 2/3 of all countries in the world. Turkey has not a well-functioning civil registration system. The Turkish Statistical Institute is responsible for compiling, evaluating, and disseminating death statistics in Turkey. Death statistics had some major problems like questionable data quality. However, these statistics include only province and district centers. Sub-districts and villages are not included. Turkish Statistical Institute, in cooperation with the Statistical Office of the European Communities, launched a program called Upgrading the Statistical System of Turkey program. A component of this program is improved mortality statistics. Under the program, a death certificate was developed according to international standards. The cause of death have been coded using ICD-10 Science 2009. Control mechanisms were developed at every stage of the registration process. Only physicians are assigned to fill out the death certificate, and all physicians are trained on how to fill out the certificate. The new death registration system, which has been put into practice in Turkey since 2009, was aimed to be evaluated in terms of completeness and accuracy in the case of Izmir province. Completeness was assessed with a question: are all the deaths in the population coverage by the system registered? Accuracy was assessed according to the level of ill-defined causes of death. Completeness was evaluated using 2 criteria. Our first criteria, completeness of death registration for 5 years old and over for 10 years period in province and district centers. In step 1, population counts from the 2000 and 2010 census round were adjusted for completeness using the generalized growth balance method. In step 2, this adjusted population data and annual intercensus deaths are analyzed using the extinct generation method to arrive at an overall estimate of the completeness of death registration for intercensus period. The second criteria of completeness was registration consistency of the Directorate of Cemeteries and the Provincial Health Directorate of Izmir. That certificate consists of 3 copies. The first copy is sent from health facilities to health directorates. Then it's sent to Turkish Statistical Institute. The second copy is sent to Directorate of Cemeteries for burial permits. Therefore, there should be consistency between the records of health directorates and the Directorate of Cemeteries. We exactly matched records of 2 institutes for 2010. The proportion of the ill-defined and non-specific codes among all causes of death in 2010 was examined in 4 categories. The first was symptoms, signs, and ill-defined condition. The second was death from injuries where the intent is not determined. The third was cardiovascular disease categories lacking diagnostic meaning, such as cardiac arrest. And the last was cancer deaths coded to categories for secondary or unspecified sites. The results of study, the completeness was of death registration in province and district centers for 5 years old and over for intercensal period were 92% for men and 87% for women. 8.9% of death records of the Directorate of Cemeteries was not fit to the Provincial Health Directorate of Izmir. More than half of stillbirths and deaths in children under 5 years of age were not reported. The proportion of ill-defined underlying causes of death was about 30%. A large part of ill-defined causes composed of cardiovascular disease categories lacking diagnostic meaning. As a conclusion, the new death registration system was found insufficient in terms of completeness and accuracy in Izmir, Turkey. Measures and investment are needed to improve data quality. The Ministry of Health should be responsible for the quality of that statistic primarily. Thank you for your attention.
Thank you. Thank you, Dr. Razieh, for that presentation. Do we have any questions for Dr. Razieh? Okay, if we don't have any questions, then thank you. Another round of applause, please. Our next presenter is Dr. Marceli de Oliveira Santos. He is the graduate in statistics and has a master's in public health and a doctorate degree in public health. He works in the National Cancer Institute of Brazil and is currently responsible for the National Population-Based Cancer Registry in Brazil. And he's going to present to us today on completeness of cancer registration in Brazilian Population-Based Cancer Registry using the flow method. Welcome.
Thank you. Onde é que bota a página inteira? Full screen. Okay. Thank you. Okay, I would like to thank the scientific committee for this invitation, and I would like the organizing committee special thanks to Isabel Savage to her support and kindness. I apologize for my English. I will try to do my best. I work in National Cancer Institute of Brazil, and I'm responsible to the National Coordination of Population-Based Cancer Registries. In behalf of the authors, Juliana, Júlio, Luiz Ivan, and Rejane, I will present to you the utilization of flow method to evaluate the completeness in Brazilian cancer PBCR. Bom, Brazil is a tropical country with continental dimensions. We have 26 states and a federal district where Brasilia is located. We can divide the country in 5 macro-regions: North, Northeast, Middle West, Southeast, and South. There are 191 million of inhabitants. The North region is the less populous, and the Southeast region is the most. There are inequalities between the macro regions. The South and Southeast regions are more developed, and the North region is the poorest. In consequence of this difference, the cancer profile is also different between regions. In Brazil, there are 32 PBCR implemented, most of them in capital cities. 22 PBCR has at least 1 year of available information. As you can see, Brazilian PBCR are different moments and have difference in quality index. But today, we can say that they are much better, and most of them have at least a reasonable quality data. Like the other PBCR in the world, their indices are better in females than in males. The percent of unknown primary location and unknown age are below 10%. The median of mortality index ratio is about 40%. The median DCO percentage is below 20%. And the median percentage of a histological verification is around 8%. The flow method was first introduced by the Thames Cancer Registry in 1995. It has a great advantage to be based on the logical flow of data in the registry system. It's based in 3 time-dependent probabilities. The probability that the patient surviving after a time t, the probability that the death certification of a patient who dies in time interval includes a mention of cancer, and the probability that patient who surviving is still unregistered. These 3 dependent probabilities are combined to obtain the cases that are missing, that is, alive but unregistered, the cases that are lost, that is, dead but unregistered, and cancer not mentioned on death certificate. And the completeness is the unit minus the case that are missed or lost. The main goal is to find if the flow method is adapted to cancer registers with low middle country profile, like Brazil, and implemented a surveillance routine of completeness. The flow method was implemented using our statistical software to 5 Brazilian PBCR to estimate completeness by sex, age, and selected tumors. We developed a pilot study with 5 Brazilian PBCR to evaluate the performance of our software and the applicability of the method. The 5 coordinators were asked to participate, and they gave a formal consent to use their databases. The database was structured in July 2011. As you can see, at the end of the 5 years, the completeness of 5 PBCR with cases diagnosed at the year 2000 is around 90%. There is no difference between genders. The worst completeness was observed in teenagers and young adults. Little cancers are more completeness at the first years. At the end of 5 years, all of them are similar. The flow method claims to be adapted to cancer registers with low middle countries profile. This method could be applied to Brazilian cancer registries and allow to a cancer registry to provide a surveillance routine of completeness. Thank you a lot. I hope to see you in 2016 in Olympics.
Thank you, Dr. Masoud, for that presentation. Do you have any questions, please? We can take 1 or 2 questions.
Yes. Could I ask, in terms of the better completeness for the more lethal cancers, it looks like maybe you're getting more from just the death registrations?
Yes. I think all the PBCR in Brazil collect the information through the death certificates. It's a source of this registry. And it is the first thing that they do when they complete their case. And then I think that these information came from DCO, and the completeness is here. In these first years, they appear more.
Yeah.
I think that is.
Yeah. And are there plans? Sorry, Max.
No, just thinking of your presentation before yours from Turkey, where it says that the death registration anyway is only 80% complete. So how would the flow method perform in that high middle-income country then?
To DCO?
No. If only 80% of deaths from cancer are actually recorded, how would the flow method perform in those circumstances?
The little cancers? Oh, I do not understand your question. I'm sorry.
I mean, actually, the point is that the flow method requires that all the cancer deaths are recorded as cancer, doesn't it?
Yes.
So I think that's not the circumstance in many low and middle-income countries. You may be lucky in Brazil that you have very good death registration, but very few people have that luxury, in fact.
Yes. I don't know what the method, the flow method, would help the DCO registration or to evaluate the completeness. What I can say is that we incorporate to the flow method the information for DCO. It's an important thing that the flow methods show us to do. But in Brazil, we have a good mortality system, and we can incorporate these information to evaluate the quality indices. I'm sorry, Dr. Parkin, but I don't know if I answered your question.
You did, yes.
Thank you.
The flow method allows to know the completeness at each moment of the process of registration, yes. So it also allows to publish data in advance, estimating the incompleteness.
Yes.
Do you plan to do also this use of the method?
Yes.
To anticipate the publication of 1 or 2 years?
Publicate? Oh, I intend to publicate, but I don't know if I can. The routine is very hard, but it is our intent to publicate these results and to do to another cancer registers in Brazil. It's a phase 2 to the project.
Thank you.
If there are no other questions, I think we'll continue. Thank you so much, Dr. Maselli.
Thank you.
Round of applause. Our next presenter is Dr. Masoud Babai. He is from Iran, and he was hired to establish the first population-based cancer registry in Iran. And his first report from the Adabali Cancer Registry came out in 2004, and he's not here? Do you have Dr. Masoud? Okay. What do we...
What we can do is we can finish this session early, but make sure that everybody has a good look at the posters.
Okay. So we have another lunch?
Yeah. So hopefully lunch will be ready.
Or do you think we should have the next presenter?
Maybe because we felt that there was we needed to finish on time for lunch, there is now a time actually for questions. If there are any questions that people would like to ask any of the speakers who have spoken in this session, because I know that we were quite strict on time. If anybody has any questions, no? Lunch beckons then?
Early lunch.
Okay, thank you.